Hello everyone and welcome to my YouTube channel. Today the topic of discussion is atrioventricular block or heart blocks. So there are three types of atrioventricular blocks: first degree, second degree and third degree. So first I will discuss about first degree AV. First degree AV block is characterized by prolongation of PR interval. So the normal PR interval is 0.12 to 0.2 seconds, and if it is more than 0.2 seconds then it is prolonged PR interval. So in this first degree heart block we will be having prolonged PR interval, and each P wave is followed by QRS complex and there will be no miss. So this is an ECG rhythm of first degree AV block, and you can see there is prolonged PR interval. So if you count the boxes, they are more than the PR interval. PR interval is calculated from the start of P wave to the start of R wave. So it is prolonged, that is 0.3. Normal one is 0.2. So the causes includes AV nodal disease, increased vagal tone, example in athletes, acute inferior wall MI, and electrolyte disturbances. So these all can prolong PR interval, and there is a disease which can shorten the PR interval, which is WPW syndrome, that is Wolff-Parkinson-White syndrome. In that syndrome the PR interval is shortened. The treatment of first degree block is, if the patient is asymptomatic then no treatment is required, and if the patient is symptomatic, like if the patient is having hypotension, acute altered mental status, signs of ischemic heart disease or signs of shock, that is tachycardia and decreased urinary output, etc. So this kind of patient will require treatment, and the best initial therapy is atropine. It will block the vagal tone and therefore increases the heart rate, and it will help in making the rhythm normal. So the most effective therapy is pacemaker. What pacemaker is gonna do is it will detect any abnormality in the heart rhythm and it will send electrical impulses that will increase the pacing, or that will improve the pacing of the heart. So the second degree AV block, it is characterized by dropped beats because some impulses from the atria fail to conduct to the ventricles, and it is of two types: Mobitz type 1 and Mobitz type 2. Mobitz type 2 is more dangerous than Mobitz type 1, and it is associated with cardiac arrest and sudden cardiac death. So Mobitz type 1 is also known as Wenke-Beck's phenomena, and it is characterized by progressive lengthening of PR interval until a dropped beat occurs, and then the cycle is repeated. However, Mobitz type 2 is far more pathologic than Mobitz type 1, and it is characterized by dropped beat without any progression of PR interval lengthening. So there will be no PR interval lengthening in Mobitz type 1, type 2, but there will be a drop beat. And what is the pathology behind type 1? That there is abnormal AV node. It can be due to inferior wall MI, myocarditis, mitral valve surgery, or high vagal tone, example in athletes. However, Mobitz type 2 is due to abnormality in Purkinje and bundle of His. So these fibers are abnormal. It can be due to anterior wall MI, degeneration of conductive system, infiltrative diseases, example amyloidosis, aortic valve surgeries, etc. So Mobitz type 1 is worsened with carotid sinus massage and it improves with atropine. However, Mobitz type 2 is improved with carotid sinus massage and it worsens with atropine. So in type 1, basically Mobitz type 1, if asymptomatic then it requires no treatment, and if it's symptomatic, the same symptoms I have mentioned in first degree AV block, if these symptoms are present then atropine is given. However, the pacemaker is the best choice. And for Mobitz type 2, whether the patient is symptomatic or asymptomatic, you have to give permanent pacemaker. So these are the ECG which are shown. So on the right hand side there is type 1 Mobitz, and on the left hand side type 2 Mobitz. So you can see type 1 Mobitz that there is prolongation of PR interval and then there is a missed beat. So you can see the first arrow pointing P wave, then second arrow pointing P wave, and there is a distance which is gradually increasing, and then there is a missed beat marked by thickened arrow. And in the Mobitz type 2 ECG, you can see the PR interval is constant. It's same throughout the ECG rhythm. However, there is a missed beat in between. This is another picture. You can see in the Mobitz type 1 or Venke back that there is prolongation of PR interval, then a missed beat. And it's in type 2, there is no prolongation of PR interval, and there is a missed beat. Now third degree AV block, which is known as complete heart block. It is characterized by complete interruption of AV conduction in which P wave has no relationship to the QRS complex. So you can see the QRS complex is present on its own pace and the P wave is present on its own pace, and there is no relation between them. You can see the QRS complex, then P wave, then another P wave, then QRS, then P wave, QRS. So the causes of complete heart block may include myocardial infarction, cardiomyopathy, severe hyperkalemia. Congenitally, it is present in infants or mother with SLE. Acute inflammation, example aortic root abscess, and infective endocarditis can also lead to third degree AV block. Chronic inflammation like sarcoidosis, Chagas disease, they all are the cause. So the patient may present with syncope, dizziness, signs and symptoms of acute heart failure. Canon A waves will be present. These waves are visible in the neck due to large volume pulse from compensatory increase in stroke volume. The Stokes-Adam attack, which is sudden loss of consciousness without warning due to episodes of ventricular asystole. So these are some clinical features of third degree. This is Canon A wave, which is shown in the neck. So the patient with third degree heart block will eventually require permanent pacemaker. So that's it for today. I hope you learned something from it. If you do, please like my video and share it with your friends and subscribe to my YouTube channel. Thank you so much.